we have a treat here now. So as I had alluded to earlier today, that a lot of cardiovascular disease in this day and age is optional, right? There's so many different things we can do in terms of risk factor management, diet, pharma, blah, blah, blah. But then at a certain point, and it's not, unfortunately, that infrequent, you get to a place where you really do need some dramatic therapy. And what's amazing, what's absolutely incredible, in 2024, this spectrum, the variety of therapy that we have that we didn't have even, Vince, when you started your short career. Yeah. But so we have a panel here of rock stars that are going to talk about specifically what kind of interventions you can do. We'll talk about the heart team, right? So we have Dr. Ramahan, who runs a cath lab and built our structural heart disease. We have Dr. Gaudiani, who's a legend in our mind, in his mind, and everyone else's mind, who is, he's a world-renowned cardiac surgeon. And when we look at the quality of care here at El Camino, to have that level of quality, Vince, has been extraordinary. And he's the kind of physician who, whenever I refer a patient to, I love it because I actually learn something in terms of the feedback he gets me. So thank you. Matt Levy he's an electrician. He fixes all those rhythm problems, and that, again, is something that has evolved incredibly since probably even in your career. Pretty extraordinary. And George Lee, who is not a cardiologist, we don't mean to diminish that. He's a vascular surgeon, and again, another area we've seen a lot of amazing innovation in this period of time that we've been in our tenure as physicians. And I think it's really most appropriate that we have Dr. Nair as the moderator of this panel. And why is that? Because Dr. Nair, he is the imaging specialist. He runs the echocardiography program here. And what do the imaging specialists know? Well, actually, they kind of know everything. They sort of see inside it, and they really know. And he is frequently the person we turn to for the final word on what we should or shouldn't do. And he's sort of the voice of reason. So Deepu, thank you very much for taking this on today, and hopefully you can keep these cats in line and get something done. So thanks very much.
Thank you, Fred. Is the microphone working, or you can hear me? Okay. Okay, great. So, well, thank you all. I'm excited to be here with this illustrious panel, and we're as Fred said, we've had a lot of discussion today about prevention, about medical therapy, but there comes a time for many people where something more needs to be done, where there might be a problem which does not respond just to regular medical treatments. And so today we're going to focus on 3 areas of heart disease, 3 separate, and we're going to do it case-based like you have for the other cases. And we'll talk about some theoretical patients and how this team might be able to help those people. So I'm going to jump right into it, and cases are pretty short here, as you'll see. So the first case is for our multidisciplinary valve clinic here, and what I want to just introduce this concept, which is this idea we'll talk more about having multiple people put their heads together to figure out the best solution for complicated problems. So this is a 65-year-old man that we're seeing, let's say all of you guys are in clinic with us, with aortic valve narrowing and some shortness of breath. So he has a history of some high blood pressure, high cholesterol, obesity, and he saw his general primary care doctor who heard a heart murmur, sent him for an echocardiogram. As you have heard today, that's an ultrasound image of his heart, which shows that he has severe narrowing of one of his valves, his aortic valve, and that also that valve looks like, instead of having 3 leaflets like a normal aortic valve would, that it has 2 leaflets. He has a subsequent angiogram, a coronary CT angiogram, a regular angiogram, and his arteries are fine, and his blood vessels in his body otherwise look fine, which will be relevant here in a minute as we talk about him. So I'm going to just start from some very basic things, pose this question to Dr. Ramahan. If you could just introduce the idea of what are heart valves and how patients might figure out if they have a heart valve problem.
Sure. The heart valves, there are 4 heart valves that separate chambers to prevent backflow of blood where they're in the direction they're not supposed to be going. And the most important one is the aortic valve, which separates the left ventricle and from the aorta in your brain. So all that oxygenated blood that comes from your lungs goes forward from your heart to your brain, and you want it not to go backwards back into the lungs. And that valve opens and closes 100,000 times a day. and you guys don't even think about it. But over time, it wears out, just like everything else wears out, and usually narrows. And so it's like the hinges on your door are getting rusty, and you have to push really hard to open the door to leave. And as it gets more, the hinges get more rusty, and the door gets stuck shut, you're going to be tired trying to get open the door. And that's what people feel. They feel shortness of breath with exercise, lightheadedness, and fatigue. And usually it's found by a murmur and an echocardiogram. And this is the most common valve problem, and it's very common as people get older in their 70s and 80s. And that's the what's called degenerative aortic valve disease. The aortic valve usually has 3 cusps. In this case that Dr. Nayer's showing, it has 2 cusps, which is actually just a congenital, it's how the people are born with only 2 cusps. It's very common to be born with only 2 cusps, almost 1% of the population. And they tend to re-narrow a little earlier because they're a little less efficient. So the valve starts to narrow in their 60s instead of their 70s or 80s.
Thanks very much, Dr. Rahman. So there's one person up here who's seen more aortic valves, actually seen them, than maybe anyone else that I know of, or most people in the country or the world, and that would be Dr. Gaudiani sitting next to me. So I just wanted to give you an opportunity, Dr. Gaudiani, to talk about the the aortic valve and your how you've seen the evolution of aortic valve treatment over your career.
Thanks. You pop this thing on for me? Thank you, sir. So the really fun thing about this and my dotage is that there's a pretty important piece of linguistics that says the map is not the territory. And so all the things that we learn about the way the heart works are maps, but they ain't the territory. They're explanatory pieces of information from which we can deduce things about the actual piece of equipment. And for the vast amount of my career, the only person who actually knew the territory in the room was me, because the cardiologists, they knew what an angiogram looks like, they know what an echo looks like, but they never actually been involved with the mechanics of the device. And what's been super fun the last 10 or 12 years, I came here from Sequoia Hospital back 12 or 13 years ago, maybe longer, no, 14 years ago. Time flies when you're having fun. So that I could be part of starting up transcatheter aortic valve replacement, which Deepu provides the map. Chad can now replace an aortic valve faster than I can, which is, that's a high praise. And we can discuss these things together because now Chad actually knows the territory like I do, because he's now fooled around with it, worked on it, changed it. And of course, it's only when you do that that you truly come to understand how this beautiful device works. And it has good sides. Like my wife says to me, you're not half as big a pain in the rear as you used to be. And I said, it's because I'm hanging around a very fine, upstanding cardiologist.
I'll take credit for that, actually.
The bad part is Chad goes home and says to his lovely wife, I'm beginning to think like Vince. And she says, don't worry, we'll get you psychiatric intervention. You can be cured. But the fun is working it out together. And the interesting thing is, if you put the patient first and you really love what you do, I'd say how many times do we disagree annually?
Yeah, we set up this multidisciplinary valve clinic. So we wanted to make it easy for patients. So patients come, they get a CT scan, they get their echo, and they see us together. So they don't have to go to one person's office, get one opinion, go to another person's office, get another opinion. And we started this, we thought we're going to disagree. Like, I'm going to say the patient needs a TAVR, and Dr. Gaudiani will say the patient needs a surgical aortic valve, and we're going to disagree. And what's amazing is we actually never disagree. Like, we're in the room together, we see the patient. If you put the patient first and you do what's best for the patient, it's very obvious what the right answer is. And we don't ever really disagree about it.
The other really important thing about this that I didn't understand, I hadn't anticipated, as I understand it now, is you can't do what he does unless you have an old dinosaur like me to help you if he gets into trouble. And I can't do big, dangerous open heart surgery because there are patients who need open heart surgery still. I can't do those cases safely anymore unless I have him to back me up, because there are things that he can fix that I can do 95% of it, but the last 5% would be fatal if he couldn't fix them, fix my whatever. And sometimes it's the other way around. He'll be doing something that would be crazy to try to do unless he had somebody to back him up. And so the back and forthness of it, and the sharing the responsibility for it, has been really, really fun in my old age. And I have really enjoyed this phase of my career, because we can now do much better things for patients with valvular heart disease than we could even 10 years ago. Much better. And so it's thrilling to be a part of it. Before I got too old and too stupid to enjoy it. It could be any day now.
I have to say it's a really remarkable thing to watch and be part of. The idea that instead of, you guys have all, I'm sure, engaged the medical system, and you're going around to a lot of different doctors getting different opinions, but to have a team of people see you as the focus and then try to come up with the best plan, that's a fairly unique proposition. So I thought two quick questions. One for Chad is just if you could talk, you kind of alluded to the role of imaging in terms of determining what you will do with these patients and the tests that you do here. If you could just quickly talk about how that influences your decision making.
Yeah, the most important test is the CT scan. So CT scan technology has improved dramatically in the last 20 years. And the CT scan is a special gated CT to make the heart not really move. The heart's moving while it's beating at 60, 80 beats per minute. Your lungs are breathing up, going up and down, and you're trying to take a still picture of this moving object and get really details. And the CTs now are beautiful. And I look at every single CT and do 3D reconstruction and measure the sizes of the valves. There are 2 valve companies that really have great valves, and we want to put the right valve for the right person with the right size. And we want to think about their life, their valve life and their life as over their next 30 years, because valves don't last forever. The valves we put in, whether it's a surgical valve or a transcatheter valve, are made of pig or cow leaflet tissue, and they wear out in somewhere between 10 and 15 years. And we want to make sure that whatever we do now is setting them up for the next procedure in 10 to 15 years. So when we see patients, we really talk about their 30-year valve strategy of what we can do for them over time. And the CT scan helps us with that, because if the valve is very, very small, then it's better if we send them to surgery. And Dr. Gaudiani really pioneered a technique of making the aortic valve larger to fit the biggest valve in, which is something that surgeons were not doing 20 years ago, and they were putting small valves in. And if we put a valve inside of that valve, it's like putting a washer in your faucet, and then the water's just kind of dripping out. So you want to get the biggest valve to get the most flow through that orifice. And so we use that CT, and we discuss with the patient and with each other what the best strategy is for this valve and what the best strategy is for the next valve.
And maybe Dr. Gaudiani and Dr. Ramahan, if you could just walk us through your discussion on a case like this one. I picked this one because this gentleman is relatively young for aortic valve disease. How would you approach this one, Dr. Gaudiani?
I'd ask Chad what he thought was the best solution. No, this is a patient you could do either way. The more vigorous he is, and the longer you think he's going to, not that we know this, but the more vigorous the patient is, and the more likely is to survive a long time, probably the more reasonable it is to do a small incision if it's not on you, but what amounts to a relatively small incision operation. Put a great big valve in there. He'll get 10 or 15 years out of that, and then Chad can put a great big TAVR inside that when he comes back at an older age group. That's what we think right now. We don't know what's going to happen in the future, but that's what we think right now. The more comorbidities the patient has, other problems that make him a weaker candidate for surgery, the more likely it is to just go stick a TAVR in him and let's see what happens. And it's not like he could never have another TAVR inside. It's just that right now, by a little bit, we're thinking the best place to start for a vigorous person is surgery, and the best place to start for any older patient, certainly, and for any less vigorous younger patient is with what's called a TAVR, a transcatheter aortic valve.
Yeah, this TAVR story is it's amazing. Dr. Gaudiani came, I think it's more than 14 years ago, because we did our first TAVR together in 2010. So you were here before that. But yeah. TAVRs have just, this is new technology, and we were at the forefront of developing that new technology here. We were in the original clinical trials that did that. And when we first did them, we actually didn't know if it would work. And so patients were here in a randomized clinical trial in our research institute that you guys have met some of the people in our research institute, where we randomized people to surgery versus this transcatheter valve. And because we didn't know it would work, they were the oldest, sickest patients who've already had 2 open heart surgeries, over 90 on oxygen. We were like, we don't know what's going to happen. We did that. And then that worked. And then we did the next patients who were lower risk, and then the next patients who were lower risk. And we participated in all those clinical trials right here at El Camino Hospital, all showing that it worked. And then the FDA and Medicare approved this. And so it leads us now to patients like the patient you're presenting, Deepu, which is like a low-risk person. 65, remember, 65 is young now, right? That's not old now. 65 is young. It's pediatric in our world. So we have a young man who's got a long, a good 30-year life expectancy, and we want to figure out what's the best thing for them. And so this patient would be considered low risk for open heart surgery. So we may be able to offer them a TAVR, but the data for these patients with the bicuspid valves for a low risk really isn't out there yet. And so we make the decision based on each patient.
That's a great summary. And I think in the Bay Area, we have a very healthy older population, and people, I did a lot of my training in the Midwest where the world's a little bit different. Here, there's a lot of healthy, active people in their 70s, 80s, and 90s and beyond. And we're often faced with this question, except the patient is 85 or 95. And the amazing thing is the technology has developed where we actually have some options that in patients where we previously didn't, I think. Would you agree, Vince?
Yes, and not only that, but there's another little piece, a little twist on this that's very interesting to me. If you got the right guys doing these less invasive procedures, whether it's aortic or the transcatheter mitral procedures, if you get the right people doing it, it can be done with really low risk. And if it doesn't work out the way you want and the patient needs an operation, we've got the techniques to go operate on them without increased risk. So they can have the less invasive procedure. And if it doesn't work out exactly the way we want, we can always operate on them next month without having lost a lot of ground. So the skillful placement of the transcatheter devices is not only important for the patient to do well in the long run, but there's nothing that's perfect in this world. For any of you who thought there were something like that, no.
Actually, it goes the other way too. So the surgical aortic valve. So I do a lot of TAVR valves inside old surgical valves. So a surgical valve's put in, and the patient does fine for 15 years, and then the pig or cow leaflet wears out, and we put another valve in. We don't do another open heart surgery. We go through the leg, and we put another valve inside of him. And I do those from a lot of them. Vince has been doing surgical aortic valve replacement for a long time. So some of them are his, and the valves are always big, and they're like lined up properly, and I'll get them from other places where they're small and they're like they didn't debride the annulus. So it actually goes the other way around as well.
Yeah, so it's a really interesting time where these fields are kind of coalescing into one field, and all of us are learning from each other, and it really is to the benefit of the patients. Given our timing here, I'm going to move on a little bit to a different subject, if you guys are okay with that. Just a quick picture of a TAVR valve on the left, which is sort of placed from the leg, is sort of going in. And then I didn't know how to represent what Vince does, so I just took a picture of the operating room. So anyways, suturing in a valve on the right. So, it's often a question of A versus B, but it's actually really about what's best for the patient, and it's not really that one is necessarily better. It's which is best for this particular situation or this patient. So we're done in multidisciplinary valve clinic for the morning. So now we have our afternoon patient here, and we've got our illustrious colleague here, Dr. Levy, and this is cardiac electrophysiology clinic. So we're going to be talking about patients who have electrical problems. So I'm changing gears. We're going to have a 72-year-old woman who has been having palpitations and shortness of breath for a few months. She had kind of ignored it for a while, but she's been feeling more and more short of breath. And then her grandson bought her an Apple Watch, and I should say smartwatch. I shouldn't be brand neutral here. So a watch that says that she has, it says atrial fibrillation. And so she goes to see her primary care doctor, who refers her to cardiology. She has some high blood pressure and sleep apnea. And along the way, before she gets to Dr. Levy's clinic, she has an echo showing that her heart function seems to also be abnormal. It's not pumping well. And she's had some other tests showing normal arteries and showing that her heart is continuously in this irregular rhythm called atrial fibrillation. It's probably something many of you have heard about, and so I thought I would start with a simple question for Dr. Levy, or not so simple, which is just what is atrial fibrillation generally, and why do we care about it?
Thank you, Deepu. So Atrial fibrillation is by far the most common arrhythmia that we see in patients. It tends to increase as people age, and so we're all healthier, we're all getting older, so we see a lot more atrial fibrillation. And the way the heart works, the way these beautiful valves work, the way the pump works, the electrical system is part of that system. And so it's what keeps things moving at the right tempo. And I will typically explain to patients how the upper parts of the heart beat first, help to fill the lower parts of the heart, which are the primary pumps of the heart. So we have a sinus node, which tends to dictate what someone's heart rate should be based on demand. So if you're exercising, your heart rate goes up. If you're at rest, your heart rate is lower. And what can happen over time is you can form little scars in the top part of your heart, which tend to be thinner chambers. And then you have this irregular rhythm where it's not just beating at a certain tempo defined by your sinus node, but it's chaotic, it's extremely fast, it's disorganized. And the heart rates in the top part of the heart in atrial fibrillation can be 500, 600 beats per minute. And that's obviously not compatible with how our heart is supposed to work. And so frequently patients come in and their heart is racing, and it creates all kinds of problems with how the heart works and the timing of the heart.
Great. And just generally speaking, at a high level, who should be concerned about atrial fibrillation? What are the key risk factors or things that you might think of as risk factors for atrial fibrillation?
Well, age is one, of course. So as we get older, people are more and more likely to have atrial fibrillation. And I think one of the more dangerous things about atrial fibrillation is many patients don't even know they have atrial fibrillation. It's always astounding to me when a patient comes into the clinic, and we've all seen patients like this, and their heart rate is 150 beats per minute, and they literally have no idea. They don't feel it. They don't perceive that their heart is racing. As far as they're concerned, they don't have symptoms. And what can happen over time is the heart can get progressively weaker, like in this patient. Other comorbidities affect the incidence of atrial fibrillation, things that you might expect, like high blood pressure and diabetes. And there are newer risk factors such as sleep apnea, and we had one of our sleep colleagues speaking earlier. And so there are these risk factors and comorbidities that make people even more likely to have atrial fibrillation. And I think in our general cardiology clinic, our general cardiologists are looking at all of these risk factors, and they're trying to modify these risk factors. Some of them we can modify, some we can't.
That's a great point. Go ahead, Vince. Oh, Dr. Gaudiani wants to say alcohol, also a risk factor.
The very important, there are big randomized control trials that show that if you drink, you have a higher incidence of atrial fibrillation. So one of the things to do, youngsters, me too, by the way, I used to drink much more wine. I used to have 2 glasses of wine with dinner now and then. Not anymore. I don't. And stay in good shape.
Yeah.
Staying in shape and not drinking alcohol are 2 of the most important things you can do. I know it's boring, but that's the truth. And so since I want to continue wasting my time with these nasty devils, I have 1 glass of wine a week maybe now, or a beer on Thursday or something. Just very, very small amount of alcohol, and stay in shape.
Dr. Gani makes a great point, because I mentioned and discussed a lot of things that we may not necessarily have control over, but these are things that we have control over, and and these are things that we can modify and change in our day-to-day lives. So thank you for that.
And I would add, I think maybe you've already said this, but obesity, another important risk factor. And one thing I want to start, whenever I see someone in clinic with atrial fibrillation, my first concern is often their stroke risk. And I wondered if you could just quickly address their stroke risk. And it's a complicated topic, but.
So Deepu and I were talking earlier. I feel like this is maybe the most important thing that I address. And it is a challenging topic because blood thinners have risk by themselves, and nobody wants to be on a blood thinner. At the same time, nobody wants to have a stroke, which can end the quality of our life in a moment. So we take a look at patients' risk factors, and generally speaking, some of the things that we've discussed. This patient is a 72-year-old woman with hypertension. So simply being over 65 is a risk factor. Being female is a risk factor. My wife always says that's not fair, but I didn't make these risk factors. And then high blood pressure. So this woman has 3 and her heart is weak, and she may have some heart failure. So this person has 4 risk factors for stroke, which is high risk for stroke. So the very first thing that I want to do is get this person on a blood thinner to make sure that we preserve the quality of their life and we keep them from having a stroke. But everyone's different. Some people have very few risk factors, and so it's a very patient-specific conversation with risks and benefits.
Yeah, that's exactly. And I think this is an important one where if you or your family members have a history of atrial fibrillation, that's maybe one of the first topics to talk over with your doctor. The treatment of atrial fibrillation could fill a whole week of discussion. So I'm just going to ask a more focused question is, in this kind of a case, how would you, or maybe more specifically, how do you generally decide which patients would benefit from ablation versus medications for AFib? What are some of the features that might make you choose one in this case?
Well, I think the most important thing is symptoms. So patients, we treat patients differently when they have symptoms, and that may seem obvious, but again, these options and how we treat AFib come with progressively increasing risk. And so my grandmother, for example, had atrial fibrillation, and she had atrial fibrillation for 30 years. So for her, when she was living in South Florida, she felt fine as long as her heart rate was well controlled. And so for her, the choice was she felt fine, her heart rates were well controlled, she was on a blood thinner, and she lived a very high quality life and passed in her 90s. But symptoms are, I think, the primary driver, as well as other problems that are being created by this arrhythmia, such as a weakening of the heart muscle. So, this has evolved in a similar fashion, that initially this was a treatment kind of for people that have failed multiple drugs, multiple other options, and it was kind of an end of the line option. But the procedure has gotten better over time, and the techniques have gotten safer over time and faster, and now there's actually some choice involved with this process. But so I have very frank and open conversations with people about all of their options, and of course I have an opinion, but I do give them the information to help make this decision together. In someone with these kinds of symptoms, with this kind of risk, I generally would first try to control their rate. I generally would first try to get them back to the normal rhythm with a drug, see if they tolerate the drug, see if it works, and based on those things, we might discuss radiofrequency ablation, which is an invasive procedure where we actually try to change the course of the disease, and in some people dramatically reduce the burden of AFib.
I want to just do one more question on the electrical stuff, and then we'll move to vascular. But and maybe I'll pitch it to both Dr. Ramahan and Dr. Levy. We have, I've heard about this Watchman device. They're advertising it on TV. Could either of you comment on brief? I know that's all of these are kind of difficult discussions or complicated discussions, but what would you think about for this patient?
So the Watchman device, or left atrial appendage occlusion, does not treat your atrial fibrillation. So we're not treating the rhythm. But we are talking about the most important thing, which is stroke risk. Most patients tell me they'd rather die than be debilitated by a stroke and have a horrible quality of life. So we're really in stroke prevention mode. Most patients can tolerate the anticoagulants. Anticoagulants now are great. The new anticoagulants are much more tolerable. You don't have to check your blood. They have less drug-drug interactions. They have less bleeding risk. So our first line always is to put them on these direct oral anticoagulants, which are great drugs. But there's a small group of patients who can't take the direct oral anticoagulants because they have bleeding risk. So they're stuck between a rock and a hard place. They have a risk of stroke if they don't take the medicine, and a risk of bleeding if they take the medicine. And so that's where this device comes in. And we've been doing this device for about 5 years. We've done over 400 of them. The data shows it's very safe and very effective at lowering your stroke risk without having to take long-term anticoagulation. We were actually just in a clinical trial for this that's going to be published for people who are not at high risk for bleeding, to see if it's an alternative for people who just want to choose not to be on long-term anticoagulation. But currently it's for people who can't take the anticoagulant long-term.
How would you approach a patient who had frequent falls?
Yeah, so that's a great. So frequent falls is a perfect one. I think now we're becoming a little frequent falls, bleeding in your stool, GI bleeding. These are the most common reasons we put the Watchman in.
All right. We're
And
gonna.
we've actually learned,
Oh,
just
yeah.
one
Oh, yeah,
second,
of course.
we actually learned this stuff from the surgeons to keep Dr. Gaudiani. So even catheter-based ablations that Dr. Levy is a master at were actually first done surgically with a cut and sew maze that Dr. Gaudiani does. And actually the left atrial appendage occlusion with the device was first done by surgeons who would cut off the left atrial appendage. So it's another example of how this sort of back and forth learning goes on.
And there's a growing number of ablation procedures involving surgical technique and
Yeah.
combining the two technologies, which is also a very interesting space.
As you can see, we're very organ-centric here on the heart. So we're going to change topics and talk about vascular system, which also matters if you also need other blood vessels. So we have Dr. Lee here from our vascular clinic, and he is. I'm going to present a different case, so we can give us some time to talk about this one. So thank you guys for the discussion on atrial fibrillation. So this is a 75-year-old man who comes in with a history of a transient ischemic attack, a TIA, which is sort of a short sort of mini stroke is often how it's abbreviated. So symptoms for this patient included garbled speech and weakness on the right side of his body, which lasted for about an hour. And he does have a history of smoking previously, had an abdominal aortic aneurysm before, which was repaired. And he had an ultrasound done in the emergency room, which shows that he has a left internal carotid. His neck artery has a 90% blockage. And then they call Dr. Lee. Along the way, he also gets an MRI, which shows that he has not had formally a stroke in the brain, though he had these symptoms. So, Dr. Lee, could you tell us a little bit about why carotid disease is important in general, and then we can go from there?
Yeah, so I'm very privileged to be up here with these guys. But essentially, as a vascular surgeon, I deal with the blood vessels, everything outside of the heart box here. And so, this is a very typical patient that we might see in the emergency room or in the clinic, a patient that comes in with symptoms of stroke. And so one of the first parts of the workup, particularly if they come to the emergency room, is to figure out, where did this stroke come from? And being a part of this multidisciplinary group, one of the places it can come from is it could come from the heart, right? And so as a part of the workup in the emergency room, they get an evaluation to see, do they have atrial fibrillation? Similar to what Dr. Levy was talking about, that can develop a little thrombus that can come from the heart. Another place the stroke can come from is obviously the carotid arteries. And so these are the two vessels that run up in the front of the neck that feed, a good portion of the brain. And so the same plaque or atherosclerotic disease that you can have develop in your heart can develop in the vessels all over your body, particularly in the vessels in the neck or in the legs. And the reason why we become concerned about carotid disease is because as that plaque develops and the narrowing gets more significant, that can increase your risk of having a stroke, in the future. And so when we see these patients that come in with TIAs or essentially mini strokes or symptoms of what's called amaurosis fugax, where they have essentially transient monocular blindness or blindness in one eye that lasts a few seconds to a few minutes, these are little warning signs of strokes where there are little either plaques or little platelet thrombi that go up and block off the blood flow either to the vessel to the eye or the vessel to the brain. And so when we find that in those patients who are symptomatic, if obviously these patients are past the point where they can have, conservative management or medical therapy, and these patients are in need of actual surgery or an intervention to prevent them from having a stroke in the future. So for this gentleman, he had a carotid ultrasound which showed pretty significant 90% narrowing in the carotid artery, and so that's probably where his stroke came from. And so for these patients, we would either offer them a carotid surgery, so-called carotid endarterectomy, which we've been doing for decades. We go in, we make an incision in the neck, we dissect out the vessel, we clamp it above and below, open it up, core out the plaque, and then sew a big patch on it so that it doesn't get narrow again. For those patients who are not good candidates for open surgery, the technology has progressed significantly to the point where we can now put in carotid stents. And what we can do here now, this is probably when you talk about vascular disease and extracranial vascular disease, this is pretty much the forefront of technology in vascular surgery as far as dealing with carotid stenosis. So this is a new procedure called TCAR, and this is essentially putting in a carotid stent, but it's novel in its approach in the fact that when we put the carotid stent in, we actually reverse the flow in the vessel going to the brain. So we actually have the blood flow coming backwards down from the brain to prevent any plaque or anything from embolizing during the procedure while we're doing the angioplasty replacing the stent. So it's pretty incredible that we can actually do this. And so this is actually one of the newest and most kind of hottest procedure in vascular surgery currently.
Great. That's a great summary and discussion of the case. I think with vascular disease, one of the difficult things is detecting it in the first place, is figuring out who's at risk. Of course, this patient came in with symptoms, but could you talk a little bit about who should be concerned? What are the risk factors for this kind of disease? And maybe also, what are some of the common screening tests that everyone might be aware of here?
Yeah, so the risk factors for carotid stenosis are very similar to your risk factors for coronary artery disease as well. So family history, hypercholesterolemia, hypertension, diabetes, significant history of smoking as well. So all the same things that you worry about that you're going to have heart disease. It would essentially we consider coronary disease or carotid disease to be a coronary equivalent. So the same risk factors apply. As far as who should be screened for this, so we don't really recommend screening patients who are asymptomatic without any risk factors, but certainly if you're asymptomatic but you have a significant family history or significant risk factors that would predispose you to carotid stenosis, those are the patients that we would recommend screening. And we actually, through El Camino Health and Heart and Vascular Institute, we've established a free community screening program where you can actually come in and have your carotid screened, have your abdominal aorta screened, as well as your legs, to see if you have significant carotid disease, aneurysmal disease, or peripheral arterial disease.
And if this patient, let's say the patient gets their carotid fixed here and then sees you in clinic afterwards, can you talk about how do you approach medical treatment afterwards for these patients?
Yeah, so after you've had your carotid fixed, either with carotid endarterectomy or carotid angioplasty and stenting, so at that point we want to then modify your risk factors, make sure all your cholesterol and blood pressure and diabetes are well managed. But after that, we monitor your carotid stenosis with just routine ultrasound, and so you'll get that on a regular basis.
Okay.
One other thing.
Okay.
One of the most important things to do.
For the audience online.
One of the most important things to do, in addition to everything you've heard, is figure out whether you've got coronary disease, because a lot of these people have coronary obstructions as well, and there are lots of non-invasive tests for that too. If I had a loved one that had a carotid endarterectomy, I would definitely put them on a treadmill, and I'd have one of my wonderful colleagues put them on a treadmill and make sure that they had normal exercise tolerance and that their EKG stayed normal while they were on the treadmill, because this disease it goes into vessels that have high flow, like the vessels in the neck, as Dr. Lee just explained, and your ticker as well. So you should be evaluated for coronary disease if you're detected to have carotid disease.
All right. Well, I think that was a great discussion. I think we can move on to, I'm getting signals to move on to questions. So I think we'll open it up to questions in the audience. Why don't we go here?
How good is this, the life scan and stuff, the ultrasound vascular test?
Yeah, so the life scan, so for those who don't know who the life scan, so essentially this is a screening program that you'll get very similar to the free screening program that we offer through El Camino Health, but it costs, I think, about $200 for the scan. It's a reasonable test, but again, these are all screening tests, and so they're a quick look to detect if you have any disease, which would then essentially require follow-up to get a formal study. Sometimes these are very quick studies. They're done not necessarily by accredited, vascular labs or things like that. And so while they may identify some degree of stenosis, that just essentially is to help you trigger a formal workup.
But a lot of false positives.
It can be, and a lot of times what we see in the life scans, it's a lot of the walking well. Like oftentimes they don't find too many things. For the patients that are kind of willing to pay for those studies. But again, I'll plug the screening program through El Camino Health. That's a free screening program. You just have to call the Heart and Vascular Institute and make an appointment. You do have to have, meet criteria, meaning that you have high risk, factors in your medical history. But that is available to the community.
In general, though, if you have symptoms, you should go see somebody who actually knows what they're doing. If you don't have symptoms, use all your attention on this beautiful world out here. Worrying about what's going on in here when there's this beautiful world out here is a waste of time. I'm dead, just philosophically, I'm dead set against it. Again, if you have symptoms and you have something you think is wrong with you, it makes perfect sense to try to stay alive and get it worked up by somebody who knows what they're doing. But all this, I don't want to use a rude expression, but nonsense that goes on, it's a way of sort of encouraging you to figure out whether your bowels are working right or whether your heart's at the right rate or not. Hey, go outside and take a deep breath and look at how beautiful this world is.
There's a lot of truth to that. I mean, with all the wearables out there, we all see a lot of patients who have extreme anxiety triggered by their wearable devices. Your heart rate hit 50 beats per minute for a minute or something like that. So, in any case, other questions? Yes, sir.
Thank you. You are the galaxy of experts. Very nice explanation. My question is, we hear a lot about arteries problem. Generally, we don't hear much about the valves. So, is it so that the nature has made valves to be non-susceptible? And what we should do to make our valves very healthy? Because here we should not have more cholesterol and plaque, but I have not heard, forgive me my ignorance, but I would like to know more about valves and how to keep them healthy and why we don't hear more about valves.
So the question is, why don't we hear more about valve disease and how can we keep them healthy? Maybe Vince, do you want, or actually, yeah, why don't I, so I would say, our ancestors probably didn't make it to the point where their valves would wear out. They would reproduce and then the tiger would eat them or whatever. So now we're all healthier, living in these societies with medications and doctors, and we have the ability to wear out our valves eventually. Valve disease also follows many of the same risk factors as you would expect for other diseases. So smoking, high blood pressure can play a role in causing valve degeneration, high cholesterol as well. And there's also other factors like infection and genetic factors that can predispose you to valve disease. But most valve diseases, with a few exceptions, are not going to occur until you're 50 plus. And they're not really diseases as commonly of young people. So that's probably why we didn't hear so much about them until this last century or so.
No, I agree with that entirely. And I also think that the best way to figure out if you have something wrong with your valves early is, and it gets boring to say this again and again, but be vigorous. If you sit in a chair and walk to your car and that's it, your valve disease is going to get very advanced before you figure it out. Whereas if you're on a treadmill 3 times a week and you are carrying out vigorous exercise, you'll figure out if suddenly you become more short of breath than you were a month ago. So being vigorous is your canary in the coal mine for most valvular heart disease.
Yeah, that's an excellent point.
But we are here, most of the people are 50 plus. Is there a test?
Well,
The test is to be vigorous, sir. The
Yeah.
test is to be vigorous. You'll do the test yourself.
Yeah.
And then comes, if you used to be able to do 20 minutes on the treadmill at 4 miles an hour, which would be a reasonable exercise for you, say, roughly, and now you can only do, after 5 or 6 minutes, you're huffing and puffing. Go see this man right here or this man right here. Stay away from guys like me, though, if at all possible.
we're going to try to take do we have a question from online?
Yes. What is the purpose of a pacemaker, and are there other options available?
Dr. Levy, that sounds like it's up your alley.
So the purpose of a pacemaker, and this is, I think when we talk about AFib, there are lots of patients that think a pacemaker treats AFib. Pacemakers don't treat AFib. Pacemakers are to prevent the heart from going too slow, generally. And so people who are on their treadmill that can't get their heart rate up above 80 beats per minute, or people that are feeling weak and tired whose heart rates are in the 40s, or perhaps people that have dizziness or they actually pass out. These are primary indications for a pacemaker.
Great. All right. Other questions in the room first? Yes, ma'am.
For the atrial fibrillation, it's very light. Do we need to take the medication forever, or we can see the situation and eliminate it?
So I think just to repeat the question, it's do you need lifelong treatment, or I think the question is, or is there some sort of cure where you could stop medication for atrial fibrillation?
That's a toughie, because sometimes the honest answer is you do need many of these medications for the rest of your life. But for example, if you were on medicines to slow your heart rate down, but we were able to kind of fix or keep you in the normal rhythm, perhaps you don't need those medications anymore. Or there are medications that we use to control your heart rhythm. Well, if you have an ablation and you're not having any more atrial fibrillation, maybe then we don't need those medications anymore. The blood thinners are a much more complex discussion, but I think these things are taken case by case, and I actually try very hard to get people off of whatever medicines they don't need to be on.
That's a great answer. And do we have another online question?
So are there any new advancements in the treatment of aortic aneurysms?
Dr. Lee.
Yeah, so that's kind of one other hot kind of area in vascular surgery, and so the newest ones are the aortic endograft, and so that's, we've been putting in aortic endograft since the 1990s. The newer advancements are mostly the development of branch endografts and things that can then treat the aorta or the paravisceral segment where there's different branches, say, to the renal arteries or to the visceral arteries that come off in that area.
Yeah, an aortic aneurysm is the aorta getting too big. And when it gets too big, it can actually get clotted in it or can rupture. And so we do surgery sometimes to prevent the aneurysm from rupturing. And we used to do a lot of open surgery. Dr. Gadiani would cut out that weakened part of the blood vessel and put just a fabric tube into place. And now Dr. Lee does these endografts, which is a stent with that same fabric on the inside of the stent to actually seal off that weakened part of the aorta or that aneurysm. And you're doing it in much more complex ways and with complex devices.
But the closer it is to the heart, the closer the aneurysm is to the aorta where the heart is. You know, the aorta extends from the heart all the way around, and it's sort of I-5 for your body. It delivers the smaller blood vessels everywhere. When the aneurysm occurs right near the heart, it gets operated on because those have very serious implications, both for rupture and for the tearing of the aorta in another way. So they still go to the operating room. We just did one yesterday.
So guys, I think we probably talk all day. It's pretty amazing how well you sort of consolidated. And Vince, I actually want to thank you. You were incredibly well behaved, and once again, you were the voice of reason. So, no expletives, and he made the most important point, which is get out and smell the flowers and chase down the birds and find some beautiful views and really enjoy life. And only when you're out doing that, if something seems to be really off, that's when you want to check in with all these super smart doctors. Well, guys, thank you very much. I appreciate it. Well done. Deepu, you kept them well controlled.